And thanks everybody for joining me tonight. I'm sure you all worked hard today. I know how that is. And I'm going to start this off with saying there is a part one of this course. So if you like tonight's course, which I hope you do, there's a part one. This isn't it really doesn't cover the same as we're covering tonight. There'll be some repetition, but if you really want to learn more, taking the part one in Catapult Education, easily findable, just throwing it out there. I want to again, of course, thank Cavo for sponsoring tonight. And as an education member, we review a ton of products. This has been one of them in the past really year. And it's just, you'll see tonight why the Diagnosticam HD is very, very special to all of our practices, but there's far more to come before that. So let's start off with a basic question. And the basic question is, do you really want to practice reactionary dentistry, which I consider traditional dentistry? You diagnose and you drill. That's reactionary dentistry. You see tartar, bone loss, scaling and planing surgery, reactionary dentistry. I really believe that we are entering into a much more holistic preventative dentistry era, because this is kind of archaic just to drill and fill. And that's really going to be our approach tonight. When you look at this x-ray, you have to realize these cavities started somewhere. I mean, they just didn't happen overnight. And so the whole idea is, when can we capture these early and be far more preventative? And now we can do far more prevention than we could do 20 years ago or even 10 years ago. So keep that in the back of your mind. So the premise is really, once you've drilled the tooth, the cycle of tooth loss begins. And the earlier in age, then obviously the tooth loss risks are greater. And so I'm going to take you through some understanding of numbers. Per published data, there are hundreds of millions of distinct early non-cavitated lesions in the United States. Hundreds of millions. Of those, approximately 40 million Americans are walking around with at least one now cavitated lesion. So it's gone from a non-cavitated, hundreds of millions, to one cavitated lesion in 40 plus million Americans. Tens of millions of teeth every year get their first restoration. Over 200 million restorations are redone annually. Over 40 million crowns are placed annually. Over 15 million root canals are performed annually. Over 15 million teeth are extracted every year, of which 60% of the extractions are due to recurrent decay or cracks. The other 40%, periodontal disease. And ultimately, over 3 million implants are placed in the country every year, in addition to bridges, partials, and dentures. Now, when you look at those numbers and realize people are living longer and longer, it gets back to the original philosophy. The goal of tonight is really diagnosing better and earlier intervention to avoid the cycle of death. So I'm going to focus all those purple arrows on a healthy tooth. How long do we keep a tooth healthy from being drilled on? And that's the key. So when you're placing a crown on a 28-year-old who's replacing an MOD composite that's broken, how long will that crown and that tooth last? And then if by 35 they have a root canal and a crown, do you really think they're going to live the rest of their life with tooth? And the answer is no way. So when you start thinking about this, we've basically been living with two diagnostics that have been the go-to in dentistry for the past 75 years. Yeah, 75 years. And really what they're all about, reactive dentistry. So what are those two diagnostics? Well, you know them. We have to really talk about the accuracy for diagnosing early non-cavitated lesions, and that's what we're talking about tonight. So let's talk about the Explorer. It seems like dentists and hygienists were born with them in their hands. When you look at the diagnosis for non-cavitated fissures, you're looking at a sensitivity that is incredibly low. And by the way, a non-cavitated early dentin lesion isn't much above 30 to 35%. So let's be clear here. An Explorer, just picking around, isn't a very sensitive diagnostic instrument. In other words, finding disease. X-rays. X-rays are around 15% sensitive, 15%, maximum 30 for identifying early enamel lesions, and really are about 45 to 50% accuracy in dentin lesions. So again, you can say, how's that possible? This is literature after literature saying the limitation of 2D imaging is very, very poor. And that's what we use every day, whether you like it or not. I can tell you I've removed so many occlusal amalgams, replacing them. And as I've removed them, there's a brown area interproximally. And sure enough, there's decay, but it's not on the X-ray. It's happened to everybody who's listening to this. And that's the low sensitivity of X-rays. So this is how I break it down. Traditional caries diagnostics is relatively poor, and that's Explorers and 2D X-rays. And I'm telling you, you have to break out of the norm if you just want to raise your bar. Where we're going in dentistry is assessing risk. And assessing risk means evaluating a patient's dental history, their medical history, potentially doing, which we do in our office, pH testing on every patient, and whether needed, salivary testing. And so that's risk assessment. And then before I even get to the next, I would go, how do you diagnose early carious lesions? It's not with an Explorer. It's not with an X-ray. And this is where we get to the next tier of diagnostics. When we talk about AI for 2D X-rays, fluorescence and transillumination. And I've been using AI now for 5 years. It continues to get better and better with fewer false positives and false negatives. I've been using fluorescence, which was the original Diagnodent, for over 25 years, and transillumination for 11 years. 11 years. Now, I'm going to show you the latest versions, but these have become fundamental in accuracy for diagnostics. And tonight I'm going to show you how to incorporate these into your initial exams and recall exams. So let's first get into protocols for new patients and recall exams. So the way I'm just going to cover this is, we'll just do an overview and then I'll walk you through it. These are all the things. Now, I set up 1 hour. I don't understand how a dentist can walk into a room where the patient's sitting in the hygiene room, pick up an Explorer, look at the X-rays, and call that an initial exam. And that's a 5-minute initial exam. It's just, that's really how it was back in the old days. This is not the old days. And I know many people still practice that way. I'm obviously not a proponent of it. So normally I book an hour. Now, I am literally 100% fee for service. I'll do and I'll show you our insurance plan, our in-office plan, not insurance. But I think it's all about the first exam, building trust, and taking the time. So this is all the things that we do. So I'll review dental medical histories. I'll determine whether I need horizontal or vertical bite wings. I use an Explorer only to evaluate existing restorations and a probe for probing. We take a digital scan on every patient for records and communication. I haven't taken an FMX in 9 years. I take a CBCT. That's not tonight's course, but I bill out a Panorex and Bite Wings. That covers my CBCT. That goes to insurance. And it's the same cost as an FMX, but I'm diagnosing far more with the CBCT and less radiation. Then I'll complete my full oral exam, and I'll walk everybody through this. 2DAI is part of all my Bite Wings and occasional PAs. I very often am using fluorescence and transillumination and always using imaging with HD. And when needed, oral salivary tested and routinely pH saliva testing also in my practice. So let me walk you through it. So the first thing I'm going to do is I'm going to walk in, obviously greet the patient who referred he or she in, and I'll go through their chief concerns, meaning I have an intake form and I want to know what they're looking for. The whole thing is listening, 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 listening. I'll review their medical history because that's key. And I don't have time to talk about it tonight. Then I review their dental history, their familial history, and their own history. Very, very key for risk. You have to be doing this. It gives you risk patterns. So that's my first 10 minutes. That's it. That's my first 10 minutes. I really, really am not even looking at their mouth. Once I get in the mouth, I evaluate their occlusion, TMJ. I'll do a full oral health exam for oral pathology. And then I'll request a CBCT, which may replace an FMX in a smaller field of view, in this case, an 8x10. But if they've got TMJ and other issues that may be more focused beyond their teeth, I get a much bigger field of view CBCT, all charged the same. So that's now I'm probably, I'll say 20 to 25 minutes into my exam. So what happens is I go now review the CBCT, which takes less than 3 minutes, 4 minutes to come up. So while I'm reviewing the CBCT, my assistant's taking her vertical bite wings or horizontal, and she's scanning the patient. So that's all done by the time I walk in a room. Based on my first look of the patient, I will then tell her if I'm going to need transillumination and fluorescence along with our digital images. Also, after my initial exam, I then will determine whether I am going to ask for all of this to be set up. And this is where we're going. And I know a lot of this is foreign to you, and maybe it's not foreign to you, but this is today's exam. Do I do a one-time only genetic test to evaluate risk? Do I do a saliva taste that's very accurate in office? Do I need an oral microbe test for perio? Do I need a combination of the above? Do I just run a plaque ID gel test, which is basically evaluating new and old plaque and karyogenic plaque? Or do I just test pH interproximally with CaviSense? So a lot of this is new. It will take time to incorporate. I'm only talking about one technology tonight, but this is the future. And once you do this stuff and it becomes routine, then your exams just set yourself apart. So don't be, and there's no real big investment in this. It's not like you're spending 50 grand to do all this stuff. But what you're doing is you're giving yourself a lot more information to be a better doctor and to provide better oral risk management. So my assistants are responsible for, of course, evaluating their digital scans. If they've missed something, they have to rescan, obviously add to their scan. They're also responsible for their x-rays. So one of the latest versions from Pearl, which is obviously 2DAI, is they have image check. So as soon as they come up, the images, if there's one of 8 errors found, the assistant or hygienist are immediately asked to retake the x-rays because there's a fault found. Now, if the assistant can go in and say, no, that's not a fault, but routinely it's a fault. So now I can walk into a room and know my x-rays are appropriate. This is all AI driven, and we will be AI driven in our future. There's no doubt about it in our practices. So this is my initial exam. I've got my CBCT read. I've got a digital scan. And in this case, I had a forwarded FMX from a previous dentist who, whatever, I won't even talk about the case. That's how I walk into a room, except usually it's my horizontal, vertical bite wings, and then whatever additional testing I want. Here's my premise. Tell the patient something, they're just going to forget it. If you show them, they'll remember. But if you're sitting them up and you're talking them face to face with all the visuals around you and you involve them, they're going to understand that they need treatment. If they understand they need treatment, they're going to want the treatment. And that becomes the key part of this. So I will absolutely tell you treatment plan conversions for me were always in the high 70s to low 80s. It varied month by month. And I'm going to tell you statistically, you're never going to close every case. So if I'm in the high 70s or a low 80, I am thrilled beyond belief to be in that percentile. Perfect? Nobody's perfect. Nobody's going to get 100%. Just doesn't happen. So one of the additional technologies, which is my focus tonight, is really a technology that incorporates imaging, HD imaging, fluorescence, and right now I'll start with transillumination. So let's understand that transillumination can detect interproximal caries at 99%. 99%. Okay, remember, a bite wing x-ray, maximum was 50% if it's an early dentin. Early enamel, 15%. Okay, AI, 66 to 80%. This is 99% accurate. So the area covered here shows a breakdown in the enamel, which is dark. It's scattered the light, and that's obviously caries on this bicuspid going into the dentin. As you take the image itself, understand that the Diagnocam with transillumination, CaryView launched this type of technology over 10 years ago. It can evaluate demineralization as early as 5%. So if this patient is somewhat carries risk, you now can treat them with a cured on-site self-assembling peptide. But you're not going to see this on an x-ray routinely because an x-ray requires 30 to 60% loss of mineral. So again, you're getting a much more enhanced image of enamel changes. So this is going to be my first controversial statement if I haven't made them all already. For adolescents, because I don't see kids, I hate them. I just treat adolescents. Anybody really below the age of 10, they're seeing my associate. But for adolescents in my practice, I routinely don't take x-rays. I don't need radiation. I don't. Why? Because I can take 4 to 6 or 8 images with my Diagnocam, as I did with my CaryView, save them, and those are my images, which are far more diagnostic than 2D x-rays. And my patients love the fact that I'm not x-raying their kids. So now the question, what about insurance? Yep, knew you'd ask. So if a patient says they want me to radiate their kids, and that's how much fun I have in my practice, I will still, and I'm going to tell you this, I still transilluminate them. I don't charge them. I charge them when I transilluminate them only. I charge them the same fee as when I'm taking a bite wing. But I don't believe in x-rays. Even with AI, and AI is great, I still want additional accuracy. So yes, I love AI, but I still want to verify with transillumination. So again, if you don't have this and you have AI, I think you're already on the way. But without AI and transillumination, I just think you're guessing. So this is how we customize our in-house dental plan. I'm going to highlight it. We include CaryView, this was our older one, and Spectra, which was our older one. Now we include the Diagnocam. So what that means is if they're in our insurance plan, or I'm sorry, in our in-office plan, not insurance, I don't want to get sued. This covers whether they want bite wings or this test. Again, you'll see where I use bite wings, but this test is routinely for my non-restored adolescent patients in their 20s because it's just far more diagnostic. So if you have questions, I'll answer those later. So this is what you normally see. This is my last version of a patient a number of years ago. Up in this box would be my traditional bite wings. But at 17, I don't need that. So I'll literally just in one piece now take a fluorescence, a digital image, and a transillumination. And it's all stored with tooth numbers in their DEXIS profile. And later, when I'm done, Trevor, who's representing Cabo, who knows this like the back of his hand, will share more details about how you store images. It's very, very simple. So what does the Diagnocam evaluate? It evaluates unrestored interproximal surfaces, unrestored. It evaluates unrestored occlusal grooves. It can evaluate recurrent occlusal decay with a lateral spread. It can evaluate marginal breakdown of existing restorations. I'll show you all these. It can evaluate cracks and craze lines. And it can evaluate all of this literally in a 2-minute scan, which I'm going to demo to you. So here's the process in 2 minutes. Let's go. So I'm going to take the Diagnocam to the back of the mouth, starting in the back upper area. And wherever I see something, I'm going to point and click. And you'll see I'm getting an HD image, a transillumination image, and a fluorescent image. If I don't see anything, I'm not saving it. So as I round out this quadrant, I've saved some images. I'm just starting now on the bicuspid going backwards. There's a composite. There's an image on the mesial, and we'll explain all this. Captured. Let's go to the molar. See how fast this is? Looks okay. We'll capture. You can see. You can see an issue on the mesial. Going to the second molar. Capture. Notice the distal of the first molar. And if you're not noticing the stuff, that's why you're here tonight. Let's go to the mandible. So it's a video, and you click to capture. Now there's something right there on the distal of the second bi, and there's your white spot lesion. Looking good. Let's move over. So imagine this is part of your routine hygiene exam and initial exam with much more information, all in this time slot of just saving images. Another issue there, right there on the mesial, we'll capture and save. So now once this is done, you've got all this data, and then the data is converted and saved. And in this case, your DEXIS software, marking the tooth numbers, so this can be used obviously in addition to x-rays or in lieu of, depending on what the patient's presenting with. That's it in 2 minutes. When you look at what the click delivers, when you capture an image, you get to see that image and really look at it. So obviously you have a HD image, a fluorescence, and a transillumination image, and we're going to get to this tooth later. So let's go back. This is traditional imaging, 15 to 30% for early caries. Step one of moving the, I'll call it the needle forward, is having AI, which is getting close to 85% sensitive. Again, you have to have a perfect shot, interproximal, no overlay. It has to be perfect in order for the AI to read it. So there's the before, here's the after. So when you're evaluating early caries, when I turn on the DiagnoCam, this is now 99% sensitive to evaluating that lesion, that early lesion on the distal. In this particular case, I have an asymptomatic crack line that you can see, or a craze line, whatever, but it was asymptomatic. It's going to guide me to evaluate the occlusion. Look at the rest of this patient's mouth. Is there a bruxism habit? Do I have to adjust the occlusion? But I definitely want to document this. Do I have to make an occlusal adjustment? Is there a balancing or working interference? All from one image that you may not see with your visual, with your literally naked eye. Then I'm going to look at the patient and look for caries risk factors. Have they had multiple fillings in the last 5 years? What's their oral hygiene like? What is the chance of this early enamel lesion progressing? If so, I can offer a treatment. Here's a little bit darker of a lesion. Again, sensitivity is 99%. But again, I'm going to go, this patient was 51 years old. They hadn't had a filling or a cavity in over 20 years. So the question is, do I treat them with Curadoc? Do I watch this and I go by their caries risk factors? Now, what I would do on this kind of patient with a low risk factor is just do a traditional varnish and follow them. But you can still offer a peptide therapy like in a Curadoc. But, and I just want to say, but, this may be an arrested lesion, but you get a much better view of this arrested lesion looking at it this way. So when I normally take my images with Pearl, and I think Overjet is quality, Vidya is quality, they're all quality. I'm trying to really enhance identification, enhance my communication, and discuss their treatment options. So now when I take this image on the upper left, and then I connect the dots from that lesion to this lesion, now you can see where the transillumination really comes in handy. So it's identified, Pearl has identified a lesion. The lesion is now noted in transillumination. Based on the width and size, my feeling is that has cavitated well into the dentin, and I'm going to have to do a class 2 restoration. But I also know I can know exactly where to drop my box. So some people believe that you have to open up the whole box. I'm not going to argue with them. I'm a little bit more conservative to this. So I'm actually drilling site specific, knowing where to drop my box, because that's what transillumination allows you to see. So then the question is, okay, Lou, that's when you decided to drill. What's the rule? When do you drill? So I'm going to take you into a study. Sounds a little barbaric, but it really wasn't. So in 1992, they took about 1,400 permanent molars and a little less than whatever, 775, 756 posterior proximal surfaces on kids. So what happened was they identified on bite wings, okay, early interproximal lesions or proximal lesions. And what they then did was they put a separator in between the teeth, I know, and separated the teeth. And the whole idea was to literally do a vivo visual examination with their Explorer and see if it was rough and catching, to see if there was any cavitation. Then they took out the separator and the teeth went back. So here were the results. So they've separated the teeth. In kids' teeth, 98% of the radiolucencies in the outer half of the enamel were non-cavitated. You're going to do Curanon. 97% in the inner half of the enamel were not cavitated. You're going to use Curanon. Here's what's striking. 72% extending into the outer of the half were non-cavitated. Non-cavitated. So it's an early dentin, non-cavitated. On these kids, you're going to use Curanon. If it's cavitated well into dentin, you're going to drill. That's your guideline. What about adult teeth? 100% of early lesions were non-cavitated. You would do Curanon. 91% were non-cavitated in the inner half of enamel. So you have a 9% risk that they're cavitated, and your Curanon would not be successful. A 9% chance. If the lesion extended to the outer half of the enamel, outer half, 60% were non-cavitated. Are you willing to try a non-invasive procedure versus drilling with a 60% chance? That's up to you. I would give that option to the patient. But once they're cavitated, you're drilling. So let's evaluate some lesions. 3 lesions evaluating caries risk. So you capture, here's the first capture. And what do you see? So you see one stained groove, one very lightly stained groove, and a little white spot interproximally on the mesial, if you're looking closely. And you can also see a white spot on the darkened groove. That's the HD mode. Let's go to the visualization with fluorescence. So here's the fluorescence, smaller groove, lighter color, darker color. Transillumination. This is the money shot routinely. So now you're looking at a groove with a light gray around it, meaning it started right now to penetrate early dentin. So this has gone through the enamel and it's starting to penetrate the dentin. Interproximally, you have an area that looks like it's in deep enamel. Pretty spread, but deep enamel. This looks like it's a very confined area. It has not spread yet. Now think about this. Routinely, you're not getting a stick, and routinely, you're not seeing anything on an x-ray. Look at all the information you're getting. That's what we're about, more information. So now it's decision-making time. What do you want to do for just this one tooth? And you can say, Lou, this is so much information, blah, blah, blah. I'm telling you, this is what you want to do to be a preventative dentist. So now what do you do here? Here's your decision. What do you want to do on this area right here? What do you want to do? There's an early enamel breakdown lesion, probably well into the depth of enamel. Do you want to drill and do a class 2? Do you want to do Curanon? Or are you just going to watch until it gets to be a class 2? What's your philosophy of care? And then you look at this early lesion. Are you going to watch that pit? What would you do with that pit? I'm just asking you questions. This one has started to spread. So for me, I'm absolutely drilling on that occlusal pit as minimally invasive as I can. For the interproximal, I'm using Curanon. And for number 2, I would micro etch that. I wouldn't drill it. And I'd use Curanon on that too. Or if you want to do a glass ionomer sealant to allow a little fluoride repair, but I'm not going to drill it. So again, I'm not telling you what to do. I'm just trying to guide you to better decision making. That's what this is all about. And it's fast. Taking the imaging is easy. It's now, what do you do with it? And I'm trying to walk you through that. So let's talk about then in the recall exam and upping our game. So this is my traditional way I block out my hour for my hygienist. And this is for prophies and perio maintenance. This is not for scaling and planing. This is my 1 hour hygiene visit. I don't believe in 30-minute double hygiene at all. I believe in 1 hour hygiene. So the first part is they're building a relationship with the patient. They're talking to the patient. They're establishing credibility, catching up with the patient. They spend usually about 20 to 25 minutes doing their prophy or any kind of debridement. The next significant part is clinical screening. Now, when you look at clinical screening, this is what we've done for 75 years. Pick with an explorer, probing, and taking an image. So our big change was a sensor. Big deal. It's a little more sensitive, maybe. I don't think so. You can use it in different ways, but film was actually more sensitive. Sensors you can do more with. But given that we're a sensor-driven profession, as we should be, because now you can use AI. But this is traditional dentistry. And I'm going to tell you, it's poor diagnostic dentistry. The additional problem, beside it being poor diagnostic, it just doesn't enhance communication at all. I mean, you have 4 5s, Mrs. Jones. It doesn't really communicate. Or I think you have a cavity on this occlusal pit. It's just not going to create the want and the need. So my whole thing for the last 26 years in private practice has been, I need enhanced diagnostics. Now, I still use explorers and perioprobes and 2D x-rays, but I'm using them with enhanced information. So I'm using AI. And obviously, I'm using these tools that I'm sharing with you to inherently just walk in a room and convert treatment plans. So what does that mean? So most offices should have intraoral cameras to talk to patients. We do use Velscope for an oral screening. We use tri-plaque gel to identify old, new, and karyogenic plaque made by GC America. Love the plaque ID gel. We use AI, 2D AI. CaviSense is a new technology determining if a pH interproximally is less than 5.5, meaning higher risk. We've converted our office to 2 diagnocams, 1 per every 2 hygienists and a doctor. We digitally scan every patient, and we do a CBCT on every new patient. That's traditional diagnostics in our practice now. I don't know if that's traditional, but that's what we use. What else have we included? We have been using GC saliva test forever to test pH and buffering, forever in our initial exam. It allows you to understand risk. We've been doing perio testing for microbes for well over 25 years. And now the latest oral salivary tests in office, we are just beginning to implement those as they have become better and better. Oral risk, which is by AI genetics, is a one-time genetic test, which has gotten to the point where they're going to be launching in the US. And just for you to know, oral biome, this is a oral cancer risk with like a 95% accuracy if someone has any dysplastic changes going on in their mouth. I mean, it's kind of amazing what all of these technologies are bringing and how they're all going to change our practice. And I'm not telling you to all convert tomorrow, but I'm showing you where we're all going. So what happens is the last part of the patient's visit with the hygienist is the hygienist reviewing her findings, and then I'm coming in to do my exam. So to me, the hygienist has already reviewed and shared her findings. That's how we do this. She has shown the patient sitting up, and she's really involving the patient. I'm walking in, and then we're going to go over what the hygienist has found. So here's a 67-year-old patient who comes in with a fractured number 18. Image taken in Pearl, AI verification. Now, why is this important? AI is identifying the depth of the lesion with an approximation. I am going to want to make sure I don't drill near the nerve. The studies show that you don't want to be within 2 millimeters of the nerve. The studies show you can actually leave an area of decay in that deep portion of your preparation. So I don't want to violate that whatsoever. But this is an identification to the patient of what we're planning to do. But now I'm going to evaluate his other teeth. So one click, just one click per tooth. I save each area that I want to save. Lower molar, upper molar, only areas I saw worth showing all of you tonight. Upper molar. So everyone is saved, stored in my DEXA software. So now it's saved. Now you're just coming in and now you're just going to treatment plan. These visuals are right in front of the patient. And obviously this tooth has recurrent decay in the HD image, recurrent decay in the fluorescence image, and recurrent decay in the transillumination image. So the HD image, you'd see a darkened gray color. In the transillumination image, you see a grayness around the amalgam. Forget the composite margins. We have recurrent decay. Now, what you treatment plan, that's up to you, whether it's a large DOL composite, an onlay, or a crown. That's not tonight's course. I'm just identifying issues. Now, here's a patient, for the same patient, number 14. Now, remember, he's an older patient. So when I'm looking at a stained HD image, HD, it's a beautiful image of the tooth, but fluorescence shows me nothing going on, nothing spreading. He's low caries risk, and I have some darkened fluorescent staining. So the fluorescence shows me some darkness. The transillumination shows me it's not deep. There's no spread. And the HD image, again, just shows black and brown staining. And by the way, the literature shows black and brown staining is more resistant to caries. It's crazy. I know you think the opposite. Here's his upper second molar. And if you look carefully, I have recurrent decay around that amalgam on the buccal surface. You don't see it on the HD image, and you don't see it in the fluorescence. So if I'm going to replace this amalgam, I'm just telling you, you can see Pearl has identified how close this lesion is to the pulp. I'm not going to remove the full amalgam. I'm going to remove the bulk of the enamel and leave the bottom probably millimeter of the amalgam in place. I don't want to take it out because I don't want to disrupt the pulp. That would enhance the cycle. This is all literature based. So now you have all these mechanisms to talk to a patient. Do you really want to wait for this decay to get worse? Let's treat it now. I'm going to be guided to do this very, very conservatively. And our last patient tonight, she comes in with symptomatic to chewing on number 13. The hygienist has a tooth sleuth ready, a pulp test ready, and transillumination ready. So here's her transillumination. We take this information, and I want you all to understand the crack transillumination is not going to tell you how deep it is. It's just not. It's going to visually show you here's a patient with a crack, but she's symptomatic. She pulp tests a 31. So she's symptomatic to the tooth sleuth upon releasing, can't chew on the tooth, and it's a vital pulp. You're going to make a decision that day in the chair. What are you going to do? Again, in my practice, I'll tell you what we did. I told her we'd have to schedule her as fast as possible for a temporary crown. Why? My goal was to drill about 2 millimeters into the crack to evaluate it, prep for a crown, put her in a temporary crown, and I took an impression that day. If she becomes asymptomatic, I go to the final crown. If she's still symptomatic, then her choice is in all likelihood going to be a root canal. If she needs a root canal, we're going to explore and see if there's any deeper crack. That means I have to take out a tooth. But it's systematically how I'm trying to save this tooth. And it turns out when I prepped this, it was deeper than 2 millimeters, but didn't look like it was a through and through crack, meaning from mesial to distal. And I temped her and called her 3-4 days later, absolutely zero sensitivity. So I knew this crack had to be superficial. but obviously into dentin. And the only way you can treat, a cracked tooth syndrome patient is full coverage, not a composite. So the goal of tonight, and I really do thank all of you for joining me. I can't thank you enough. I wanted to share with you how we've updated our initial exams and our recall exams. Really a whole host of ways to enhance diagnostics and how they can be incorporated really into your daily schedules, leading to more consistency in really how we diagnose early cavities, but far more. And I do feel this is the future of our profession. And I believe this is the standard of how we diagnose today in our practice. And many of you will also. Thanks so much. So, Sophia, I think right now I'm on time. Crazy, I'm on time.
All right. The first question we have in the chat this evening is, can you do anterior also with this?
Yes, you can absolutely transilluminate anterior crowns. You can transilluminate buccal lesions. Absolutely, yes.
What do you charge for the Diagnocam?
So bite wing x-rays in our practice, I think, are $88. So on a teenager who we are not doing x-rays on, I just charge the $88. The issue is if the parents have dental insurance, insurance won't cover it. So then I have to take x-rays. I bill $88 and then I don't bill Diagnocam. If the parents say, I don't want radiation, then it's, Sophia, it's an $88 charge, just like bite wings. And it is offered in our in-office dental plan, which includes everything at no charge.
Great. Are you performing RNA testing on all new patients to identify the bacteria that is actively causing the tooth decay?
Not yet, but I would tell you right now we do triplaque ID gel on our high caries risk patients. That's for sure. We will be instituting the next level of oral salivary testing to evaluate various periopathogens and pathogens for caries, yes. But I think that's all being right now refined for market release in Q3 of this year. It wasn't up to what we needed prior to this presentation. It's just not there, I think, yet, but I think by Q3 it will be, based on what I understand.
All right. And the last question we have is, how much are you charging for the new patient comprehensive exam?
So I think it's a bargain, everybody. I do. I don't discount it. I really don't. I charge $175. And I think it's a loss leader in my practice, because obviously I want to be billing for 4 or 5 or 6 times that amount, but you need that time to build a trust in all of your practices. So openly, I'm talking to the patient. I'm trying to understand the patient, evaluate on the disc profile who they are. How am I going to be effective with them? They're all different patients. So it's a loss leader. I know 175 is a lost leader, but I think that if long-term they're going to be with you for the next 10, 20, or 30 years, that's the lost leader I'm willing to take care of.
So we have another question.
Great.
So,
Send them away. Come on, let's hear them.
They said, thank you. I'm overwhelmed with the cohesiveness you have incorporated new and old techniques. Your comprehensive exam is thoughtfully executed for my 37 years of practicing. What are your thoughts on SDF and xylitol?
So to begin with, thank you for the compliment. The reason I've changed over the years is that I found traditional diagnostics, I was always wrong. Things were there that we were constantly missing. You think it's a small cavity, you take your fissurotomy burr, and you can see the enamel dent. It's a huge lesion. Same thing for interproximal. So SDF. I'm a huge SDF lover for cavitated lesions. Now, I don't treat kids, but for geriatric adults that have just overt caries problems, I am using SDF, and I use Riva Aqua which is a two-part SDF that doesn't turn the teeth as black because it's followed by potassium iodide. It's a 1-2 combination sold through distribution called Riva Aqua. So and there's a sequence of how to use SDF. SDF alone or SDF then followed by probably a resin modified glass ionomer in geriatric patients. So I do absolutely believe in it. Xylitol is a great product to be used in the right dosing for higher caries risk patients, no doubt about it. And so I think both products have an absolute place in our offices. And I will tell you, by Q4, I believe the market's going to be rocked with more peptides coming out to treat early lesions, and also a non-blackening SDF that releases hydroxyapatite. So I do think later this year, you're going to see some new products coming out that will even enhance more of your prevention style.
All right, those are all the questions for oh, sorry, one more.
I got
Caries as
easy.
a
I got off
disease.
easy.
I know, I was like, wow.
Wow.
Caries as a disease requires a substrate sugar. What do you recommend for diet counseling?
Wait, say again?
Caries as a disease requires a substrate and a sugar. What do you recommend for diet counseling?
So what's interesting, what's really a fascinating question. So 50% of all caries is genetic. 50%. And that could be shocking to you. But there was a classic study for everybody on here called the Vipahome study. What they evaluated was in the 1950s on a tremendous amount of Swedish kids in Sweden, I think it was. And what they basically found was the sugar and the caries effect of sugar relating to risk. But what was also interesting is that those kids on high sugar diets were much greater to have caries risk. They also found a very interesting proportion of people who inhaled the same or consumed the same sugar and weren't at caries risk, which showed, same diet, genetics. So genetics can affect your buffering capacity, your acid in your saliva, all the additional things, including bacteria. So when you talk about sugar assessment, absolutely, I will tell you, we talk to every patient about not only home care, but obviously dieting and the right way to consume foods. And so to me, obviously, sticky foods are the number one cause. But I will tell you, interproximally, we know our patients don't floss. So I'll tell you what I would write down is one word, and it's called the Slate Power Flosser, SLATE. If you go to slate.com, get a complimentary power flosser. This will change how you approach flossing in all your patients. So the key thing is we want to minimize plaque. So one is home care. Last point, I recommend right now for higher caries risk patients, one toothpaste and only one toothpaste, and it's called Live Fresh. LIVFRESH. Why? It reduces plaque 250%. Plaque. It reduces gingival bleeding, gingival plaque inflammation score tremendously compared to traditional toothpaste. So if you have patients who are not caries risk, low perio risk, traditional toothpaste are fine. Live Fresh is for your higher caries risk patients. I just tell you, it's worth you exploring both Slate and Live Fresh. That's how we try to combat our caries at-risk patients. But you have to talk about diet counseling, sugar consumption, how often they're doing it, etc. Sorry to be laborious in my or voluminous in my answer, but I think that's a complicated 2-minute answer.
So this is a good one. Do you have more courses? If so, how can I take them?
I would tell you this. Part 1 of this course is on Catapult education. If you take the course, you get a CE credit, and it dives a little bit deeper into all of this stuff. And then honestly, if you go on the site and Google my name on the Catapult education site, you're going to see a ton of courses. And this relates to restorative implants and perio, because this has been my core focus for the last 30 years. So thank you for the compliment.